This is Dr. Amanda from StraightSmile Solutions, and today we're going to be talking more about Invisalign and elastics. I know I have a couple other videos out there. They're a little more generic in nature. We're going to be talking specifically about Invisalign and elastics today. And why should you use elastics? Well, I mean, it makes your treatment plans way better, and it's a feature that's included in Invisalign in the light and in the comprehensive case, so why not use them if you can? They do all the work for you. All you got to do is have your patients wear it. So just real quick and short, Class 2 elastics are always going to go from upper canines to lower first molars. Sometimes you need them unilaterally, sometimes you need them bilaterally. They're probably not going to tell you. The techs are not going to tell you when to use them. You need to ask for them. Okay, so if you're not getting a great treatment plan, or you're not getting AP correction of the canines or the molars to Class 1, then that's a time to think about using them. Class 3 elastics is the opposite. That's for negative overjet or edge-to-edge occlusion, correcting underbites, mild, maybe 1, 2, 3 millimeters. Those are going to go backwards. So they're going to go from lower canines to upper first molars. For the most part, you can, if you don't have an upper first molar, you can use it to the second molar. If you want a greater vector of force, you can do that too. Just remember, StraightSmile Solutions is glad to teach you when to use them and what cases they're appropriate for. So feel free to connect with us. We have a case-by-case support. We have unlimited support. Our fees are crazy low, so please visit StraightSmileSolutions.com. How else can we wear elastics? Well, I mean, sometimes you're just looking to settle the bite, but to be really honest, for those cases where you have a posterior open bite, I don't like elastics. I'd rather just use a positioner. They're way cheaper and way easier. So yeah, check out my previous videos that I did today on positioners and what I recommend for posterior open bites with aligners. But in any case, yeah, that's Class 2, Class 3 elastics, super easy. With braces, there's so many more formats and patterns that you can use, but really easy. It's just going to hook on the upper canine on the slot. Put those on first before you put them in. The molars should have an anchor of a button. You can buy those from the Invisalign store. I would put the aligners on first before you bond it to make sure that you put it in the right place. It shouldn't be right against the gum line. It should be kind of in the center of that little slot that you create. But it should be really easy. And remember, patients do need to wear them 24/7. The way that the bite jump feature works in the ClinCheck is a little bit nebulous. It's not always exactly accurate as what you can expect to see clinically. So you can't necessarily just go by that. So you're going to wear your elastics full time for most of the case, but if at any time you start to see the bite progressing too far advanced, you might want to step it back to night times. And I can explain more what that means on a case-by-case basis. So yeah, don't forget to visit StraightSmileSolutions.com. We'll be glad to explain elastics to you a little bit more. It's an awesome feature that Invisalign offers. Dr. Amanda from StraightSmile Solutions, and we're going to be talking about elastics today, intraoral elastics. I'm going to be piecing a couple other videos that I already made onto the end of this video. There's a good video about using elastics and aligners. It has a lot of the points in there as well. So as long as we're learning elastics, we might as well learn them for aligners and for braces. Same concept, just different way to hold on to them. So, and slightly different strengths. So here's our type it on again. Let's go ahead and talk about the 4 main elastic patterns we're going to talk about today. And then make sure you take pictures at the end of your module and email them to us of the different elastic patterns that we've asked you to do. So we're going to ask you to do a Class 2, a Class 3, a triangle, and a posterior box. That's 4 separate assignments, okay? And each one should have 3 pictures is fine, front, side, side, okay? So the elastics I would stock, okay, would be probably 1/4 inch medium, 1/4 inch heavy. And if you want me to write these down, I can. 1/8 medium, 1/8 heavy, and 3/16 medium, 3/16 heavy. Medium is 3.5 ounces, heavy is 6 ounces, I believe. So that's a total of 6 different elastics, I would say, to stock. I think that's probably all you're going to need. With braces, I tend to use medium to heavy, of course, maybe more heavy if I can. I don't use elastics for Class 2, Class 3, unless they're in a heavier rectangular wire, okay, not in round wires. Class 2 elastics are going to go, for the most part, from the canine back to the molar, the first molar, but can go to the second molar, okay, if you're trying to get more of a vector of force. but most of the time this is fine, okay? Most patients are probably going to be able to use 3/16, but if they have a really big teeth, you might have to use 1/4. Sometimes you can use a smaller diameter at night and a bigger diameter during the day if they're complaining, but that's pretty much it. Class 3 is the opposite. It's going to go from lower canine to upper molar, okay? So what's the objective of class 2? Class 2 elastics is for overjet, okay? Or if we're trying to direct the space closure in that kind of direction. So if the front teeth are sticking out, we're trying to get the overjet closer together, we're going to use class 2 elastics. Class 3 elastics we're going to use if it's the other way around. Maybe they have an edge-to-edge occlusion, or if we're trying to direct space closure in that direction. You're going to get it eventually, but right now we're going to keep it pretty simple like that, okay? And be sure you stick with us on some of the case selection and treatment planning modules so we can teach you more about class 2 and class 3 elastics. Posterior box elastics, we have some great videos on that already. Those you can use in round wires. I like to be at least in 16 niti in order to use it. Usually I'm going to use 1/4 inch, and you'll see some videos following, but it's going to go canine, canine, molar, molar. Okay? And that's pretty much it, and triangle is right here. So go ahead and practice the 4 different modifications for elastics, take some pictures, and show us what it looks like. All right, and if you don't have a hook, you have to put a Kobe on. That's pretty much it. And today we're going to be talking about bite turbos or bite bumps. We're going to be talking about these because a lot of people are getting these with their braces and they're not understanding what they're for. So you can see here in the picture, these are some like handmade ones. These are made out of a composite material, which basically means composite is like it's not a ceramic, it's not like glass. It's basically like a plastic that can glue to your teeth. So it's not any different from a filling material. It's just that this is made blue so that we can identify where it is so that we make sure to remove it all. So sometimes you're going to have your bite bumps on your front teeth. Sometimes you're going to have them on your back teeth. They may be on the top. They may be on the bottom. You might even get them on your canines. It really depends on the personal preference of the doctor and maybe what they're trying to accomplish with them. So what are some of the reasons you might get bite bumps? Well, the number one reason that people put them on is to prevent patients from biting down on their bottom brackets. Now, not all patients have that problem where they might bite down on their bottom brackets, but some do if their bite is a little bit deep. And do take a look at some of my other YouTube videos to learn more about deep bites and how they're corrected. But that's the number one reason. Your doctor may be of the opinion that you shouldn't have these, and instead that they'll just put the top braces on first and put the bottom ones on when it's time. So that is one opinion. There's really no wrong or right opinion, and people have very strong opinions on this topic. So, don't take it. You can always ask your doctor what they think is best. So what are some of the side effects from getting bite bumps on teeth? So it's important that you do understand the side effects, because if you understand this, you'll be more aware of what's normal and what's not normal. So for top teeth, if you put them on the back of the front teeth, what's going to happen if you get these is that you're not going to be able to bite fully down anymore. That means your back teeth are not going to touch anymore for a period of time until you're done with these. This can make it very tricky to eat. So it's a double-edged sword. Number one, great. You got your bottom braces on. You're not breaking things anymore. That's wonderful. Number two, you can't eat things anymore very well. Soft things, yes. But, like meat or something like that, you really can't chew things up very effectively more. So you're going to have to eat a pretty soft diet until your teeth start to match up again. These may be on 6 months to 12 months, and over time, it will get better as your bite starts to change and accommodate for this. So it can be very rough initially, I won't lie. Number two, your front teeth might get very, very sore because you're putting more pressure on them. So you can take some Motrin to alleviate the discomfort. Again, as your bite will start to accommodate, this will start to go away. But you should be aware of the side effects so that you're not pretty shocked. And if you are, first getting braces for the first time, you should make sure you have lots of soft foods around the house, Jamba Juice, yogurt, stuff like that, that are easy to eat for patients. Really, really soft foods, spaghetti, stuff like that. So what happens if you get these on your back teeth? It's not quite as challenging to get used to. If you get them on your back teeth, you can still eat, but you can't bite with your front teeth in that case. So, either way, it can be challenging. So in any case, I just wanted to explain a little bit more about bite bumps. If you have any questions, let me know. Don't forget to go to StraightSmileSolutions.com, connect with us on our Facebook forum, both doctor facing and patient facing, and submit your questions. We're going to be talking about class 2 and class 3 elastics with aligners. And what to do if you're not using Invisalign. Obviously, if you are using Invisalign, it's significantly easier. Here's an example of what their precision cuts will look like. You can see here. Can you see it on the canine? I'm going to go ahead and hook that on for you. Now, in terms of what elastics to use, you're going to really have to try them in your patient and see. There's no wrong or right answer to this, and it really depends on the morphology of the teeth and the bite. So let me show you what this looks like. See, this would be for a class 2 elastics. It just hooks right on there. And then down on the bottom, it's going to go ahead and hook to the lower molar. You can use either the first or the second molar. You could either use a button or you can use precision cut to precision cut. So many, many options. It really depends on your personal preference. So we're going to go ahead and show you a diagram shortly about that. If you're going to go from button to button, you can do that too, actually. You can probably use heavier elastics. You might be able to use 3/16 heavy or even possibly 1/8 heavy. If you're going from precision cut to precision cut, it's going to be a little bit different. In that case, let me do that for you. I'm going to set one up for you. You're going to have to use a lighter elastic. In that case, it's going to be a little more challenging because you are going to have to make sure that they're not getting displaced. So let me show you kind of what that looks like. And this is, I'm using a combination of ClearCorrect and Invisalign. But so that's going from slot to slot. Okay. So that means the patient is going to go ahead and assemble this outside the mouth and then put it in their mouth all at one time, as opposed to going from button to button where you're going to put the aligners in first. The buttons will already be on the teeth and then hook the elastics on. So personal preference, what you want to do. What if you want to go ahead and punch your own precision cuts? Now, again, we showed the demo of Invisalign, what it looks like. The good thing about Invisalign is because of their scallop trim, it's super easy to put the hook on a relatively low profile. If you're going to punch in your own, it gets a little bit uglier. And you'll kind of see what I'm talking about, because if there is no scallop trim, when you try to punch in your own, it's not going to work. So you're going to have to create your own slot. So let me show you what this looks like. You have to play with it a little bit, but this is for the class 2. You can see here. So what I was using to do that was, I'm going to give credit where credit's due. So the pliers that I was using, these are made by Justenko. It's a company out of Sweden. And you can see here, this is the slot puncher. I have a couple other videos on that. If your aligners have straight line trim, like ClearCorrect or some of the other in-house aligner white label companies, you are going to have to get creative with your punching. This is how you do the molar punch out. That's a little bit easier. You can see here, I'll show you what that looks like. So here's where I did a molar punch out down here. Okay. And really I would put it on the patient first, and just kind of mark where you want to do it. It needs to be in the center of the clinical crown, and you need to be able to get the whole button on there and a tiny bit of enamel along the gingival so that it's not kind of seeping on the gingival as you bond it, because it's probably not going to stay on. So you need to make sure you make it high enough. This is probably an example of how not to do it, because it's a little bit off center and I think not high enough. So I'll try to reposition that for you. But okay, so let's talk about the opposite. So here we go. I'm popping it right now. Woo, that's a little bit better. Okay, maybe a little bit more centered. Okay. What if you want to do a class 3 elastic? Class 3 elastic is the opposite. So you're going from, and we'll go ahead and show you a diagram now. We're going from upper molar, so you can either do the 6 or the 7, so you have to think about that, to the lower canine for the most part. So it's opposite, right? So upper molar to the lower canine. Let's see if we got one punched out here. Nope. Yes. So here. This is actually an upper now. We just turned it into an upper. So there's your upper molar cutout, or you can do a slot. I'll make a slot for you right now. You can see how to do that. Again, these are not the prettiest, but I do find that when you have a straight line trim, you're kind of at a disadvantage for this. You really are. Let's do that here. I'm not really doing it in front of you guys, but Okay, so I kind of ran it to the 7 here, but here, this is for class 3. So upper molar slot down to lower canine. If you want to go slot to slot, you're going to have to go lighter on elastics. If you want to go button to button, you can go heavier on elastics. Again, the elastics I'm usually using are, on the small end is going to be your 1/8 medium to 1/8 heavy. On that larger end, maybe 3/16 to maybe 1/4. Depends on the morphology of the teeth, the bite, the patient's musculature, so many things. So you really need to try in the elastics before the patient leaves the office and make sure that they can comfortably get them on and get them off in a timely manner. I'm going to give them about 1 or 2 minutes. And if they can't do it in 2 minutes, you know, either have them practice more or change the elastic size. If they cannot do it, then they're not going to do it at home because, I mean, and you guys should be able to do it too. I'll be honest. I mean, initially, unless you have nails, you're probably going to use one of these to put the elastics on. But if you can't do it with your nails, the patient can't do it with their nails, okay? So, and the patient's not going to take this home. I mean, there's elastic hook, things that you can use it, but realistically, is the patient going to carry that around? No. So make sure it's something that you can do before you assign it to your patient. In order for elastics to work, some tips, you have to wear them 24/7, 24/7. Maybe you can have maximum 2 hours per day while you eat. If they are only wearing them 18 hours a day, it will not work. You will get zero outcome on this. So it's like a seesaw effect. It's just going to be sore. That's the only thing that's going to happen. So you have to make sure that your patient understands this 24/7 and not just 2 weeks, 3 weeks. You're talking about months to get, I would say if they wear it aggressively, and you did right by your sizing, you should see about 0.5 millimeter to 1 millimeter a month of AP change. By AP change, I mean the bite correcting from the anterior posterior direction. That means if they have a 7 millimeter overjet, it's going to take at least 7 months to correct that. I mean, that's even on the max. I don't know in an adult if you're going to get that much correction. That's maybe in a kiddo. In an adult, the max you're going to get with elastics is probably 2 to 3 millimeters of correction, and that's if they're awesome. In a kid, maybe you can get up to 6 to 7 millimeters, and that's if they're awesome. But like I said, that's going to take minimum 7 months of 24/7 wear. When the patient comes in for their checks, you need to be measuring them and taking photos. You should see, if you're only seeing them every 6 to 8 weeks and they're honestly wearing these 24/7, you'll see a change. If you don't see a change, they didn't wear them. So, and you need to be confident in telling them that. So, I mean, a little confidence with elastic goes a long way because, patients or kids are like animals. They can sniff out fear and it's a lack of self-confidence. So you need to have the confidence. But again, if you didn't size the elastics right, guess what? It's not going to work. So it all comes down to whether you sized it right. So hopefully I didn't blow your mind too much with these instructions, but there's an art to wearing elastics and there's an art to getting a good outcome. So any questions, feel free, send your questions our way. StraightSmileSolutions.com. We'll be glad to help you with aligners and elastics wear. All right, thanks so much. And today we're going to be talking about class 2 elastics. I'm directing this kind of series of videos really towards the general dentist, towards the pediatric dentist, doing some, fixed orthodontics, maybe has some questions. I tried to Google search out there to show my clients and there's really nothing out there. So basically, a lot of questions I get are, what's a class 2 elastic? You can see how the orientation goes. In general, it's an elastic that normally hooks from the upper canine to the lower molar to correct an overjet. The actual size of the elastics is going to really vary. I'm talking about the diameter is going to vary on the amount of overjet or the size of the teeth. So you really should stock several sizes. I would recommend stocking 1/8, 3/16, 1/4. Those are some good ones to stock. Then there's also strengths. Normal class 2 elastics, I'm going to use 6 ounce. But it also depends on what wire I'm on, and we can go into that more later. So do message me, visit StraightSmileSolutions.com if you would like some more suggestions. But normally I'll run my elastics on a heavier wire. I'm not going to run it on an eye-tie wire. It's going to be a stainless steel wire. I know that's really different than a lot of other IDB systems that are out there. And I'll run 3/16 heavy. But
Again, you got to stock lots of sizes. It's not a one size fits all approach for elastics. There's some thought that needs to go into it. Do not run it on a light wire. All sorts of crazy things are going to happen. And that's basically all about class 2 elastics. Take them on, take them off. Every time you eat, they absolutely have to be on 22 hours a day. No ifs, ands, or buts. If the patient only wearing them 12 hours, 16 hours a day, they're not going to work. There's just basically a seesaw effect, and there's going to be significantly more discomfort. So if you do not establish this with the patient and the parent, at the beginning, they're not going to see success. You should, I'm going to say confidently, you will see a change if you're seeing them on 6-week intervals and the wearing elastics. It will be evident. Okay. It should be quite evident, as a matter of fact. So if you're not seeing the change, you need to be confident in saying you're not wearing them enough. They may be wearing them 16 hours a day, but you need to troubleshoot. That means they need to be changing the elastics at least 4 times a day. Every few hours, they should be changing it. Usually I say 4 times a day: breakfast, lunch, dinner, snack, bedtime. That's 5, something like that. It's okay to change it more. You should be dispensing at least 2 bags of elastics every time that they come to the 6-week interval check. So, and remember, as you're correcting the bite, the wires are going to get pokey. You got to trim it, right? And you still got to check the patients. So yeah, that's all about class 2 elastics. And I get this question a lot with my customers, with my doctors. They ask me a lot about rubber bands, especially the patients, whether they're Invisalign or they're in traditional braces. The question is, what size, what orientation should I prescribe for rubber bands? What's the best way to wear them? How do I know if it's the right size? So I'm going to take you a little bit through some rubber band formats and see what you think. So here, it doesn't matter what kind of rubber bands you use. There's all different ones. The main thing is you want to make sure that they're new rubber bands, because over time, rubber bands do degrade. Here, I'm using Ormco brand, but many different options out there. These are the colored ones. I would recommend latex rubber bands. They're a little stronger than non-latex. Of course, if you have a non-latex patient or latex sensitive patient, that's a different story. But from there, basically, some of the popular ways that you would wear rubber bands. Let's start today with, say, box elastics, okay? That's a popular one to try to settle the bite. So go ahead and take a look here. If the bite is a little open or deep, a little bit deep, and you maybe have some bite ramps back here, you need to settle the bite. You usually will wear them from the 6s to the 3s, basically making a rectangle. How to pick the right size? Goodness, it really depends on the bite of the patient. It really depends on the teeth. But ideally, it's best to find the smallest possible size that the patient can comfortably take on and off. And if the patient is in between sizes, usually I recommend maybe picking a slightly bigger and a slightly smaller size. They can wear the bigger one during the day, the smaller one at night. And I'm talking about diameter right now. I'm not even talking about strength, okay? Because there's a whole grid. They come in different diameters and different strengths. So you can go ahead, and for these, usually I use, you can use 3/16. You can use quarter. Right here, here's a 3/16 right here. This is a little bit heavy. Okay, so now we're going to talk about strength a little bit. This is 6 ounces. 6 ounces is a little bit too heavy if you have a light wire. So I wouldn't recommend it necessarily if you're in a light night tie. But this is what I have here. So we're going to go ahead and show you how to put them on. The patient shouldn't walk out of your office until they can comfortably take the rubber bands on and off a few times and show your assistant that they can do it, okay? So there are little hooks to help you out, so you can give the patient those. It's a little harder to do it on a Typodont sometimes, but nails do help. And there we go. There's a nice little posterior box elastic. And if you have the hooky, it helps more. Just make sure the patient can comfortably do it. Show it a few times. Give the patient time. Don't stress the patient out. On, off, on, off. Okay, you're great. If it's a child, show the parent that the child can do it. They need to wear these elastics, usually on both sides, 22 hours a day, minimum. That means they're in all the time, unless they're eating. As soon as they're eating, they're brushing, they're putting them back in. Another common question is, how often do you need to change the elastics? Well, pretty much every time you eat, you should be discarding your elastics, which are now overstretched, and putting a new pair in. So that's at least 4 times a day. So if you're seeing your patient every 6 weeks or so, you should be giving them 2 bags of elastics. They should blow through those pretty quickly if they're wearing them right. If the patient's actually wearing the elastics, you will see a dramatic change in the bite by the next visit. If you're not seeing a change in the bite, they're not wearing them right, or they're not wearing them as much. Thing about elastics is if you wear them 16 hours a day, it doesn't work at all. you have to wear them that 22 hours a day. There's a sweet spot in there where otherwise you're basically just rowing a boat. You're going forward, you're drifting back. You're going forward, you're drifting back. So anyways, that's what I have to say about posterior box elastics today. This is Dr. Amanda with StraightSmile Solutions, and today we're going to be talking more about elastics. I think there's a lot of confusion about different types of elastics, what the configurations are, why you use them. And this could be not only on traditional braces, but also on aligners. So they can punch little divots out in the aligners, and then they can put buttons in, and you can wear elastic formations on that too. Your doctor will tell you how to wear the elastics, and there's a reason for every formation, but this is just your traditional, I would call this a box elastic configuration. It may change. It may not be like this. The box could be like, here, 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 here. But it's basically to close a bite and to get your teeth to touch more in the back. Like if you're not touching on all your teeth. That's how that's a reason I would wear a box elastic. On this side, we have a type of triangle elastic. Again, the triangle could go here, here, here. It could go here, here, here. But it's a 3-point configuration. And that is usually to close a bite, or to close a bite and correct a bite like an overjet, or an underbite, or to bring a canine down. So that's what a triangle elastic is. And again, you need to listen to where your doctor tells you to hook them. You will need a hook on any tooth that needs the elastic. And the size and the diameter of your elastic will really depend on the size of the teeth, how the bite is, the strength. So there's size and there's strength. So for example, I think it gets confusing. This is a pack. This is by Ortho, but you can see this here. Elastics come in different diameters. These are in inches. So this is 1/4 inch, and this is 6 ounces. So I would call this 1/4 heavy. For braces, that's fine to use heavy elastics, but if you're using aligners, I usually go medium, which is 4 ounces to 4.5 ounces. For braces, if I'm going to use a 6-ounce elastic, I need to be in steel wires or very heavy nitrile wires, because if you use heavy wires on heavy elastics on light wires, you're going to get a lot of bowing that goes on, and that's not healthy. So, because it's just not stable. So in any case, this is really more for the patients out there that have questions about why elastics, and for the doctors who have challenging time selecting the elastics. Remember, when you're selecting your elastics, you should have a lot of different sizes and diameters. You need to start off with the strength, whether you're going to use the heavy. I usually only use heavy and medium. I don't use light very often. I might use light if there's like a super high up canine or something, and we're in really light wires. But in any case, heavy or medium, so it's either going to be 4.5 or 4 ounces, and then 6 ounces for intraoral elastics. And then in terms of diameters, I generally use 3/16, sometimes 1/8, 5/16, and 1/4 are the ones I generally use. So those 4 different diameters are my most common ones. So I would definitely stock, I would stock at least 8 of them. If you're going to use those 4 diameters plus heavy and medium, that means you should be stocking 8. And when you give your patient their elastics for the month, or for the 6 weeks, or for the 8 weeks, one of these generally lasts, if they're changing it 3-4 times a day, like they should be minimum, this is going to last about a month. So you should be giving your patients at least 2 bags of these. I would say in between appointments, if they're in aligners, you may have to give them 3 bags if you're seeing them every 8 to 10 weeks. So hopefully that helps explain elastics. Hey, this is Dr. Amanda with StraightSmile Solutions, and today we're going to be talking about closing anterior open bites with elastics. And this graphic that I drew here is an easy way to understand it. Now, of course, picture that your patient is in braces, okay? So we've got braces on. I just want you to understand the elastic geometry and how this works. So at this point, first of all, as I always say, take a step back, because if your patient has an open bite, it might not be something you can correct with just ortho only without jaw surgery. In that case, you're going to need to refer to an orthodontist. So it really depends on the etiology of the open bite. And so I always say you need to figure out why it's there first, address that first, and then you can do the braces or address it concurrently. So open bites don't just happen. They can either be skeletal in nature, which is just the way the jawbone's formed. That could be a result of an airway problem, past or present habit problem or things that maybe happened in childhood, feeding issues, stuff like that. Bottles, pacifiers, thumb, finger habits, digit habits, stuffed animal habits, pencil habits, stuff like that, right? Or an occluded airway, either nasal or pharyngeal. So if you don't address that, you're never going to be able to retain this open bite. It doesn't matter what you do. It doesn't matter how many bonded retainers you use. So you got to figure it out, right? But let's say, for example, this is a 15-year-old patient. Let's say the open bite is only really from canine to canine. It's an anterior open bite only. It's not a posterior open bite. The smaller the open bite is, the more isolated it is to the anterior teeth. If you've totally corrected the habit and the airway issue, you've done a sleep questionnaire, and you know this is just something that you've now corrected and you just need to fix the sequelae of, and you're sure there's not a tongue thrust, then you might be able to address it if it's anterior only. So there's a lot of layers that go into the complexity of this. So in this case, I mean, this is a pretty exaggerated open bite. This may not be possible to be able to correct stably through braces, even if you fixed all the problems that caused it, okay? But you can give it a shot. That's the main thing you could do. And you definitely would want your patient to sign a compromise form. So they realize that jaw surgery is the best for this patient. They've chosen to give it a shot. That way, if it relapses, you're not liable. So you need to make sure you do that. If you don't do that, then you very well may be liable. So just be careful in taking these patients. I always recommend that if possible, send them to an orthodontist. At least they can go over what the surgery would be like. If the patient declines the surgery and decides to go with your compromise plan, then so it is. You know, they understood their risk, benefits, and alternatives. You've documented them. You grabbed a signature, and now you are no longer responsible. But okay, so putting all that aside, that's my standard spiel. Anterior box elastic is going to be, you can do it in a medium elastic as long as you're in night tie. I wouldn't do it on a 12 night tie. I wouldn't do it on a 14 night tie. Ideally, I'd want to be in an 18 night tie, which means we've done most of our leveling, aligning, and stuff like that first. This anterior, you're going to have to put Kobe hooks on the lateral incisors. I've got videos on how to do that. You can just search up Kobe, K-O-B-I, and it should come up under my videos, Kobe hooks. This will probably be 5/16 medium or 1/4 medium would be my guess if I had to guess. These side ones, if you may not need to do these. If the anterior open bite is only here, you don't need to do these. But if there is an open bite that extends to the canines, then you'll probably need to do 3/16 medium on these. Now, if you're already in a rectangular wire, a heavier rectangular wire, you can do heavy. So, but this is only if you're in a round wire, would you do the medium. So again, 1/4 or 5/16 medium on the anterior trapezoid or box. If you needed to add these triangles on the sides, probably 3/16 medium. And if you're an 18 night tie, if you're in a rectangular wire, you can do heavy. So hopefully that helps. Remember, again, once you correct this, you most likely are going to need a canine to canine bonded retainer covered by an Essex as well. So there's a lot that you're going to need to retain this, and there's no guarantee it's going to retain. If the patient does have a tongue thrust, forget it, it's not going to retain. So be really careful in picking these cases. Hey, this is Dr. Amanda with StraightSmile Solutions, and thanks for your suggestion. Today we're going to talk about Kobayashi hooks. There are long ones, there are short ones. You can use any ones you want. They come in different sizes. My favorite usually is 012 or 014. Find out which one works for you. The different diameters or gauges of the wire help it adapt or not adapt, or held up a rubber band a little bit more. I usually like the long ones instead of the short ones. That just works for me. The short ones for me are tricky, because for me, they tend to break brackets, but you know, everyone's different. So I get a long one. I go ahead and tie the patient in first. I want to put it on once for the rubber band, and I don't want to deal with it again. So that's how I do it. Okay. So everyone's tied in nicely. This is a long one. This is an 012. First thing I do is I go ahead, and this is too long. If I try to put it on like this, it's going to poke the patient's eye out. Okay. So I'm going to go ahead and trim it. So you want to get a nice sharp pair of lid cutters or pin cutters or whatever you guys like to call them to trim it. Okay. Trim it good, about halfway down. Okay, this is, of course, I said get a nice sharp one. This is not a nice sharp one. But in any case, then what I do is I curve it. That's just me, comfort curve, so I don't poke the patient's lip. For a top arch, I'm going to put it on like this. For a bottom arch, I'm going to put it on like this, okay, towards the gingiva, so you can hook an elastic. You can put Kobayashi hooks on any bracket that needs a hook. So sometimes they come with hooks, sometimes they don't, depends on how you order them. So let's go ahead and, for example, let's put it on, okay, this lower central right here, okay? So I curved it, just like I said. Patient's open. I'm going to go ahead, slide it on. Okay, I'll give it a good tug. Good tug right here. Okay, and center your hook the way you want it. Okay, if you want it on the distal, you can see here, I went ahead and I put it on. So basically you're going to twist it just like I started showing you in the part 1 video until it starts to double back. Once it starts to double back and make a curly Q pigtail, you're going to go ahead and cut it with a couple millimeters of tail left over so you can tuck it under. You can see it's not very well tucked here, so I'm going to go ahead and show you what I do next. In order to tuck it, I like to use a ligature director. They come in all different sizes. This is what I use, but you can also use your nail. That's what a lot of people use, okay? So you go ahead, put that in there. Hopefully you can see it and just tuck it under. These things come in different diameters too. So there we go, tuck it right down. Good, there we go. And that's nice and comfortable. And now you can go ahead, throw your rubber band on, however you want to wear it, maybe like this triangle, and you're all good to go. These occasionally do come loose. If the patient says that they get pokey, you can have them put wax on it. One of my favorite tricks is to tell them to use a pencil eraser to tuck it in. That's better than using a toothpick or something sharp where they might gouge their gums. But ultimately, if they start to get loose and wiggly, tell the patient to come back and you can replace them. This is probably commonly what you're going to see. So number 3 is going to be take the last aligners or whatever aligners they're in and trim them distal to the 3s, distal to the canines. So you're just going to have anterior alignment. And then you can go ahead and place buttons on the posterior teeth. 1, 2, 3, 4, 5, 6. At least every posterior tooth should get a button. So that means premolars and molars bilaterally. So put those buttons on. You can get them in clear or metal. The patient's probably going to want you to have clear. And then light cure them. And then you're going to go ahead and dispense elastics, okay? You're going to need to probably stock a variety of sizes of elastics. I'd get 1/8 medium and heavy. I'd get 3/16 medium and heavy, and I'd get 1/4 medium heavy. That's 6 different types. I would always keep in stock. And then you'll need to go ahead and have them run elastics in triangular patterns, overlapping triangles. It doesn't matter if they're upside down, how you do it. Bilaterally, there should be probably about 3 elastics on each side. They need to wear those 24/7 along with their aligners on their front teeth. And for a couple of weeks, they can come back, I would say every week to 10 days, come back. This happens pretty aggressively. And once you get them stabilized and you have a good bite, again, retain it at night for at least 2 to 3 weeks, and then you can put them in there. Hey, it's Dr. Amanda with StraightSmile Solutions, and today we're going to be talking about Class 2 Vector Box Elastics. So these are things I use all the time in a patient where maybe we are already aligning and leveling, but we have a deep bite or a heavy overbite. Usually I do them in conjunction with some anterior bite turbos or an anterior bite plate. So anterior bite turbos, you can see some of my previous videos. If you can't find them, message me, I'll send them to you. That's where you put some bite turbos behind 8 and 9 to open and lift the bite. An anterior bite plate is a banded appliance that is acrylic and it runs off the molars, but either way it works the same way to help to level the curve of speed. So I do these more at the beginning of treatment in heavy deep bite patients. Normally I'm going to do a traditional box elastic, which is going to go from here to here to here to here, right? It's a nice box. All these are included, but this is a class 2 version of it, which means we're going to have a small class 2 vector, almost like a class 2 elastic, which would be like this, right? Split down the middle, but not including these. So class 2 elastic is just 2 points, this one and this one, and ours has 4 points. So ours helps to settle the bite and provide a class 2 vector. So anyways, I just wanted to explain that to you.
This is Dr. Amanda with StraightSmile Solutions, and we're going to go ahead and talk a little bit more about face bows, face masks, and how to attach reverse pull headgear to an appliance. So thank you so much to Specialty Appliances for this sample. You can see here that this is a mini expander, and they've soldered on Facebook hooks to the anterior of it. You can solder Facebook hooks on pretty much any maxillary appliance, fixed or removable. You just have to ask for it. Usually it's at a small additional fee. These are fantastic. If you have any kind of anterior crossbite, I would strongly recommend that you get the hooks soldered on. And if you need them, you need them at the end. And if you don't, you don't. But at least they're there so that you can use what is a very excellent appliance to jump anterior crossbites. I think it's the gold standard by far, and it's not even expensive. It's not painful, and it's really easy for both patient and doctor. So we've done some other videos about how to adjust the actual face mask, and we referenced the Facebook hooks, but now we finally got a sample with Facebook hooks. So yay, let's go ahead and show you how to do it. Okay. So what I do is almost all Facebook cases, or face mask cases, I'm going to go ahead and do expansion first. Why? Because the vast majority of them need it. 2, it helps to loosen up the sutures theoretically so that you get more success with the face mask. So I do them on both removable and fixed. So once we're done with the expansion, then I go ahead and do the protection face mask portion of it. You need to wear your face mask 16 hours a day. Please reference the other videos in terms of how to adjust that. But the elastics usually I'm going to use are actually not these, but they're going to be probably 8-ounce, 1/2 inch for the most part. These are extra oral elastics. These don't come in little bags. These come in gigantic industrial bags of like 1,000 each, which I really don't need for my demo. So I'm just showing you an elastic. But you will need to buy the big bag of elastics and then dispense, a little bit in a Ziploc bag. So it's pretty easy. The patients are just going to hook it on to the hooks, okay? And, so you need to make sure these are not, impinging. So you might need to adjust these out with a plier so that they're not bothering the patient. But I was able to hook this on. So you go ahead and hook it on, and then you do it on both sides. And then you go ahead and advance it and attach it to the face mask hook that is on the face. And they sleep in this. They wear it around the house. It's on both sides. You do not need to wear that to school or anything like that. They're just going to wear it sleeping. It's waterproof, so you could wear it showering, doing your homework, gaming, watching TV. So it shouldn't be too hard to get your 16 hours in. I mean, bare minimum I'd like to see is 14 hours a day. If they want to wear it 24/7, be my guest. You can do that too. Here, now I've got it on both sides so you can see this. Okay, but it's relatively easy to go ahead and hook it. And it's not painful at all. Sometimes the force will loosen up the appliance, so just let them know if it gets loose to go ahead and come back in and get it re-cemented. And sometimes you might need to use a little bit more industrial cement on this, like a glass ionomer, instead of your regular band lock or whatever. But, you can give it a try. It really depends on how well your bands are fitting. And if it's a removable appliance, you need to have some really great clasps in order to make this happen. But anyways, you should see 1 millimeter a month of correction of AP, correction, advancement of the maxilla, if you're actually doing this correctly. So if the patient's actually doing it correctly, you will see visible changes from one appointment to the next. If you're not seeing visible changes, they're not doing it correctly. So it's real easy to have confidence when you prescribe this appliance. And what else? Yeah, I mean, most times they're going to wear it for 4 to 8 months, maybe. I would always over protract because you're going to get a tiny bit of relapse when you stop using it. So get yourself at least not just edge to edge, but some majorly positive overjet. So you have some wiggle room when you go ahead and discontinue it. So anyways, that's how a protection face mask works. And today we're going to go ahead and jump into class 3 correction. We're going to be talking about class 3 correction in growing children. I'm going to talk to you a little bit more about something I've been wanting to do for a while, which is talking about face bows, reverse pull headgear. And I think a lot of dentists are very intimidated by this, and it's really actually not that big of a deal. It's actually easier than you think. So I'm going to walk you through it with a demo. First of all, before you start jumping into doing something like this, you need to really assess the patient and check a few things first and make sure this patient is a good candidate for this procedure. How do we do this? Number one, you're going to go into looking at the panoramic x-ray, looking at the growth, checking out the skeletal growth, checking out the age of the patient, how much growth is left, the direction of the growth. I do encourage you, matter of fact, I don't just encourage you, I strongly recommend that any patient you're going to do this on, that you go ahead and have a Ceph, and not only have a Ceph, but have numbers on the Ceph. If you do not know how to interpret these numbers, you can connect with me. I'm glad to help you on this and train you on this. It's actually quite inexpensive to have it done for you, but the actual interpretation, you need a little context behind it, because what you're trying to look for is a predictable case to do growth modification, class 3 growth modification. A small percentage of class 3 patients are so severely skeletally, deficient that they're most likely not going to be able to be successful with this procedure. And those patients, we need to flag them and make sure they're getting to ortho and getting in the right funnel later for the jaw surgery. Doesn't mean they can't go ahead and go through these procedures, but they really need to go through it with an orthodontist. But if it's a very minor correction, you can go ahead and do it yourself in office, in-house. All right, anyways, so this is my favorite kind of reverse pull headgear. This is something that's been around for 100 years. There's nothing new to this. It still works the same way, and it's extraordinarily effective. We're not just tipping teeth, we're growing jaws. We're helping to advance the airway. We're making the airway bigger. It's a win-win-win for the patient. You really can't go wrong with this. The main thing is compliance, and the good news is the patients don't have to wear it to school. So I have zero problems with compliance with patients. I also know what I expect from the patient. I know what I expect to see from appointment to appointment. So if they're not wearing it, then we're going to go ahead and call them out, let the parents know. Of course, you can use like a compliance program like dental monitoring, which I think is amazing for this kind of thing, because you really don't need to be seeing these patients that regularly, but you do need to be checking in on them. Okay, so first thing you're going to go do is take your reverse pull face mask out. This is my favorite type. It's really streamlined. It just goes right down the middle. There's ones that have 2 bars on the sides. Those are very uncomfortable to sleep with, so I would highly recommend this one. Okay, so there's 2 components to it. There's the forehead component, and then there's the chin component, which is right here. This is the component that you're going to use to attach the elastics. All 3 of these are movable with a hex screw. So keep in mind, I'm going to fit this to myself, and I haven't done it yet. So I'm literally winging this as we go along. You're going to get a hex screw in the package. Don't lose this. Don't give this to the patient. Make sure that you keep it just in case there's a problem, because you don't want them trying to modify it themselves. So you're going to go ahead and loosen up your hex screws. Okay, this one may not loosen up too much. So loosen them all up, okay, and keep them relatively mobile. You're going to go ahead, usually I'll start with the forehead one. It's kind of loose. Just kind of put this where this goes. Oops, trying to center this. It's a little different doing it in a mirror, right? Okay. Oh my goodness. It's so much easier doing it on a patient. Like this, okay? So I guess I have a big head. Kids are a little bit different. You can go ahead and mark it, tighten it, nice and tight. Okay, so now I should have my forehead and my chin part done. Why am I crooked? Okay, well, don't do it crooked on your patient. Okay, it should be lined up with the middle of the face. Okay, something like that. There we go. Okay, so this part is pretty good. Maybe I'd put the forehead up a little bit more. And of course, have it less crooked. And then this part right here should be downwards and forwards of the occlusal plane. So something like this. Okay, so you're going to go ahead and secure that as well, so that it's all nice and flat. Okay, and then that's pretty much what it is. So once you got that going on, now another little tip that I can give you for these is that these really tend to get really sweaty. They give you extra pads in the package, but they get really sweaty. The kids tend to get like breakout, especially during the summer. So you might want to line them with moleskin. Like moleskin, like from Dr. Scholl's, works really well. Or you can put a little like talcum powder or like cornstarch so that they don't get sweaty. But I like the moleskin. I think that works really well. So I like to reline it. Well, yeah, I mean, that's pretty much it. You're just going to wear it like this. And then you're going to have to attach it to some type of appliance. Usually I'm going to go ahead and do either an expander, some type of fixed expander, removable expander, something like that, to go ahead and loosen up the sutures first. the vast majority of patients that need some type of protraction face mask are also going to need expansion. It's all part of one deal. So I don't think I've seen anyone that couldn't benefit from it. So go ahead and make sure you finish your expansion first. I usually wait till the expansion's done so I know where it is. Then I start this in the retention phase of the expansion. You can have hooks soldered on your expander or on your Schwartz or on your sagittal or whatever type of appliance you have. And the elastics will go from the hooks that are right here to these little kind of zigzag bars right here. Usually I'm going to use 8-ounce elastics on each side. Hang on. I'll show you how to hook them. This is not 8-ounce, but at least it's an elastics. This is 6.5 ounce. Sometimes people will just do double, like 2, but you need about a 1/2 inch. Like the regular elastics are not going to work, like in terms of diameter, because they're not going to stretch that far. But you're going to have to try it in. So there are some companies that make extraoral elastics. They don't all. So, but basically you're going to go ahead. Oh my goodness, making it crooked. And you're going to go ahead and hook it like this. Okay, 1, 2, all the way on the back, both sides, bilateral. Okay. And then it's going to be the mandibular plane, the occlusal plane should be moving downward and forward, just like normal growth. So it shouldn't be straight out. It should be downward and forward. So when you try it in, it should look really even, really balanced, not like canted at all. And the plane should be going downward and forward, probably 8 ounces, 1 8-ounce elastic on each side, probably a 1/2 inch elastic, but you might need a slightly bigger diameter elastic in order to hook on it properly. So you might need to get a couple different extraoral elastics. Sometimes people will increase the force to a little bit more than 8 ounces on each side, but I would say start with that and go from there. So that's pretty much it. They need to make sure that they're wearing their protraction face mask or reverse pull headgear minimum 16 hours a day, bare minimum. So that means it goes in the second they're done with school. They wear it during homework, gaming time. They take it out to eat dinner. They put it back in. They wear it for bed. It shouldn't be falling off. The pieces shouldn't be loose. They shouldn't be mobile. It should be relatively secure when they sleep. If it's coming off when they sleep, you need to reevaluate that. Sometimes the force of the protection face mask will loosen the appliance if you have a fixed appliance. So that just happens. Be prepared for that. If you have like a negative vertical, like if the lower teeth are blocking the jump of the upper teeth, you might need to put some bite ramps on or some type of appliance that has occlusal acrylic so that it can jump better. So, but ultimately, if you wear this, you should see about 1 millimeter change per month. If you're not seeing 1 millimeter change per month, guess what? It's not getting worn. So, or it's not being worn the minimum 16 hours that we're saying. So if they're wearing it 10 hours, just at night only, it's not going to work. You have to wear it 16 hours. And they can wear it more than that on the weekends. If they want to wear it all day long, great. They're going to get amazing results. Things are going to go quicker. So encourage them to wear it more than 16 hours. Because usually most patients, when you tell them 16 hours, they're like, okay, that means I can just wear it 10 and get away with it. No, you need to be very clear. This only works at 16 hours. How long will they need to wear it? Well, it's about, like I said, up to 1 millimeter a month. If they're actually wearing it properly, if they're wearing it subpar, it's not going to work at all. So it's a waste of everyone's time. How many millimeters do you need? Basically, how much advancement do you need? You're going to have some relapse when you stop. So you always want to advance a little bit more than you need. But for the most part, I can easily get 3-4 millimeters of advancement with this. I might relapse 1 millimeter. But that's just, if you can get it from an edge to edge bite to a positive overjet with a little extra slack, you're pretty much good. Make sure your vertical is pretty good too. And then you just got to keep an eye on it because they can, depending on what type of growth issues they're having, if it's just maxillary deficient, usually you're fine at that point. But if there's mandibular prognathism, you're going to start to see some more problems possibly creep up later. But again, this only works if they're still growing. So you should know how to analyze growth in a patient. And if you don't, feel free to connect with me. I'm glad to teach you.